my channel Learn OBG with me. If you have not subscribed my channel, please do subscribe my channel, and if you want to learn more about OBG, please go through my channel, and if you have any doubts, you can write it in the comment section, and you have any queries, you can write it in the comment section as well. And today let's learn about this massive transfusion protocol template. In our daily routine practices, we see many of the cases in not daily routine, but sometimes we don't even expect such situations where the patient will go into the hemorrhagic shock, where our minds will get blanked at this moment. In such cases, most of us, our brains will go into a blank position where it doesn't work at all, because we will be in a tension why the mistake and where the mistake has been happened. In that tension, we will actually make some other mistakes. So in any type of a case, like wherever you see the patient is in hemorrhagic shock, in such cases we have to we have to take the help of the other units as well, and we all should work in a team, and everybody should support each other at this time. So in which cases we have to use this transfusion protocol, please bear 10 minutes of time with me, so that we have to learn this very important topic, where nowadays it will help us in a lot of positions. So this massive transfusion protocol, in a conditions where you will have the massive hemorrhages, like for example a long bone fracture has been happened, or if the surgeon is doing some surgery, there is some thoracic injury, something has happened at the time of surgery, or abdominal surgery, or at the time of the obstetrical surgeries, right? The patient suddenly they will go into the severe bleeding, and they will land up in hemorrhagic shock. At this time we need we need to actually plan for this massive transfusion protocol. Usually when we should at this time, what we are supposed to do, how we are going to work, we'll learn in this class. So at this time, what one person will do is, as soon as the senior clinician, whoever, will determine that she is going into the shock, she will ask for a help. So in such case, they will immediately inform the multidisciplinary team, where it will all involve the surgeon, main surgeon, the anesthetist, the hematologist, and the therapist. If required, the other surgeons can also include. So whenever they determine the case, like they are going into the hemodynamic shock, but as soon as the anesthetist will get to know about this condition, they will try to stabilize the patient, because as she is going into the hypovolemic shock, the demand for oxygen to the organs will be high. So they may land up into respiratory acidosis, or metabolic acidosis, or alkalosis. At this point of time, the anesthetist have to be very cautious, and if needed, they'll go for the intubation, and they will try to maintain the saturation levels, and the other person will try to secure the IV line, and at the same time they will send some of the investigations like CBC, coagulation screen, like PT, INR, APTT, and fibrinogen levels, and required any biochemistry lab investigations. And we should also check for the ABG levels, so that we will understand in which pH levels the patient is in, so that we will manage accordingly. So this is one thing, and at the same time don't forget to confirm the blood group and take another 2 tubes, so that you will send it for the blood bank to reserve the blood, and the other person will call the blood bank and will tell them that there is a need of the hematologist support, and also please arrange some of the blood, there is an emergency situation. So we need more pins of blood, and if required, please arrange FFPs, and if needed, cryoprecipitates as per the surgeon or the multidisciplinary team orders. So the blood bank will become alert at this point of time. So when we are sending the lab investigations, we have to particularly check for the coagulation screen and the HB levels, at the same time arterial blood gas levels, and also don't forget to check the electrolytes, particularly ionized calcium. You don't forget to check it. And so next, the hematologist will actually look after all the investigations, and he will plan how many pins of transfusion and what kind of transfusion to be done. So usually, as per the hematologist or the senior clinician request, usually for 2 pints of RBCs, we will give 1 pint of FFPs. So in such cases, if it is a massive transfusion protocol, previously we used to use 1:1:1 protocol. So now they are using 4:2:2. So 4 pints of RBC if you are transfusing, 2 pints of FFPs are required. And as the blood is being arranged at this point of time, we actually have to stop the ongoing blood bleeding, right? So at this time, the only thing that we have in our hands is the tranexamic acid. So immediately, as soon as you suspect bleeding the site and all, immediately give off 1 texakyne 1 gram IV, so that it will do its work, and later we will until the blood comes, we can at least help the patient for time being. So at this time, as we have sent the fibrinogen levels as well, but consider this fibrinogen levels, it should be more than 1 gram per liter. If it is less than 1 gram per liter, then you have to go for cryoprecipitate transfusion as well. Now, after this massive transfusion protocol, transfusions have been done, you will also estimate, and in the time being, if there is a need of surgery, the surgeon will act. And the surgeon will decide whether there is a need of more time or what anta. So in this meantime, we should see that whether the bleeding is controlled or not. If it is controlled, it is well and good. If it is not controlled, then we have to consult the hematologist and the need of the transfusions as per the hematologist request. So in this case, whenever there is a case that we are treating, at that time, first thing that we have to do is we need to identify what is the cause of such bleeding, and at the same time you need to call for help, and you are sending immediately by the time the surgeon comes or the multidisciplinary team involves, immediately secure an IV cannula, put off send off all the investigations like CBC, blood grouping, and also keep one cross match as well for the blood transfusions to intimate the blood bank. At the same time, fibrinogen levels, PT, INR, and all. Then initial measures you have to take care, like if it is a fracture, you go for a tourniquet, or you can go for a compression. If it is a surgical cause, from the surgical site, like in obstetrical cases and all, so any kind of a PPH or anything that is going abnormal, then we have to immediately involve the surgeon. We have to call and inform them. So in time being, we will do all these things, and as the team comes, we should the profile also will come. At this time, if the platelet count is going less than 50,000, then we should order for the platelet transfusions. If the INR levels are going more than 1.5, then we have to order for FFPs like 15 ml per kg. If the INR is 1.5, more than 1.5, then we have to order FFPs 15 ml per kg. If the fibrinogen levels are less than 1 gram, then we should go for cryoprecipitate up to 3 to 4 grams. And in the time being, we can give 1 gram of Texakyne within 10 minutes. Then we can go for infusion of 1 gram of Texakyne for 8 hours we can keep. And at the time of resuscitation, the main anesthetist will see that patient is not going into hypotension, patient is not going into a hypothermia, and they will also, at the same time, they will also avoid the excessive crystalloids, so that the fluid will not escape into the free spaces. And also they will try to maintain the blood pressure, so that they will help the surgeon in the meantime. So for example, if the bleeding patient was on warfarin previously, and on table they were bleeding because of some tensions, we forgot to ask about the warfarin, let us think. So, and on table we got to know that patient was using a warfarin. In such cases, what to do? Then we have to use the antidote. What is that antidote? Vitamin K. Okay. And in cases of the obstetrical hemorrhages, the patient will usually land up in the DIC cases. In such things, we have to go for the cryoprecipitate. And in cases of the head injuries, see that the platelet levels are at the level of more than 1 lakh, and see that the blood pressure is also maintained. We don't use this recombinant factor 7A, but I don't know whether they are using out of India, but here we don't use this recombinant factor. In such cases like trauma and all, only we will consider. If it is considered, then we can consider it in cases of an uncontrolled hemorrhages in salvageable patients, and also for the patients who had undergone a failed or the radiological measures to control a bleeding and adequate blood component replacement. And at the same time, their pH also should be maintained above the level of 7.2, and temperature should also be 34 degrees centigrade. And we have to also discuss with the hematologist if still there is any need of any further medications or further needs of transfusion, then the hematologist have to take place. Thank you for watching this video. If you want any topics, you can write it in the comment section, and like the video. Please subscribe my channel. Thank you.